Hi, now let's look at psychological disorders. Now this chapter outlines several categories of mental health disorders and explain the symptoms used to diagnose particular disorders. For each type of the disorder, we're going to consider the possible reasons why a person behaves in this way. Now, although the research presented may seem overwhelming at times, keep in mind that these explanations are closely tied to topics in which you already are familiar. For example, many of the symptoms of mental health disorders are physical in nature, involving brain functioning, neurotransmitters, hormones, genetics, biological factors. These were all introduced from Chapter 2. And many other symptoms also relate to psychological concepts such as cognition, which was in Chapter 3, and learning and emotions, which were in Psychology 1. Not that you have taken Psychology 1 necessarily, but in the field of psychology, these are all important elements to psychological disorders as well. Now remember, this topic of psychological disorders is a separate branch of psychology. It's known as abnormal psychology, and it's a very big branch. It's also important to note that please do not, and I will say this a couple of times through this video, please do not diagnose yourself or diagnose anybody else. We are not skilled or practiced enough in the field of abnormal psychology. We're not psychiatrists, and we are not familiar with the DSM-5 diagnostic tool. Therefore, this chapter is an overview of psychological disorders. Should you find this topic really interesting, consider taking Abnormal Psychology Gen Ed in the fall semester. So let's get started with psychological disorders. In order to start, let's first determine what differentiates normal from abnormal. And we're going to look at some conditions. One condition: is the behavior considered strange within the person's own culture? Now this highlights that not every culture sees behavior in the same way. What might be abnormal in one is normal in another. And so is it normal within one's own culture? 2, does the behavior cause personal distress? That is to say, is the person's life somehow messed up as a result of the behavior? Are they so fearful about going outside that they don't go outside, therefore they're not able to hold a job? Personal distress. 3, is the behavior maladaptive? Is it an inappropriate or a poor decision or poor way to go to solve a problem? Is it maladaptive? 4. 1 is considered strange for the culture. 2 is personal distress. 3 is maladaptive. 4, is the person a danger to self or others? That's self-explanatory. And then 5, is the person legally responsible for his or her acts? Now, there are 5 perspectives that attempt to explain the causes of psychological disorders. You can find this certainly on page 254 in your textbook under what is labeled as Review and Reflect 1. I will go through them briefly, and we will revisit them, and you've already seen these throughout this course already. There's a biological perspective, which views it as a symptom of an underlying physical disorder. So the biological perspective looks for what biologically in us is an underlying physical disorder that it would explain the psychological disorder. 2 is the psychological or the psychodynamic perspective. This maintains that it is caused by unconscious, unresolved conflict. And that's the hallmark of psychodynamic. It looks to the unconscious and it looks to unresolved conflicts, often from childhood. 3, the learning perspective. Now, the learning perspective argues that it's learned and sustained in the same way as other behavior. How I learn to write, how I learn to do certain things has all been based on reinforcement, positive or negative, or punishments, positive and negative, in which case learning is about how we learn things that are not good, or how we learn behaviors that are problematic, as opposed to, or in the same way that we might learn other behaviors. 4 is the cognitive perspective. And this suggests that abnormal psychology, if you will, or psychological disorders, is a result from faulty thinking. And how we faulty think about other things can also fall into psychological disorders. And then 5, we're going to look at the 5th, which is humanistic perspective, which views that psychological disorders is a result of blocking one's own natural tendency towards self-actualization. And that makes sense given how we've seen that the hierarchy of needs, where self-actualization is at the peak, that all of these other elements need to be achieved to get to that point. And if we're blocking here, then we're maybe interfering with something that is interfering with our growth, and therefore we are being affected by psychological disorders. So as I mentioned earlier, the primary diagnostic tool is the DSM-5, and it's used to assist mental health professionals. Now, we go in much more detail with the DSM-5 and use it throughout the semester in abnormal psychology. The DSM-5 was published by the American Psychiatric Association, the APA, where you get your writing from, your writing style from, the APA formatting. It's from the American Psychiatric Association. Now, the DSM-5 published by them is a system most widely used in North America to diagnose psychological disorders. The most recent version of the DSM described about 300 specific psychological disorders and lists the criteria for diagnosing them. Not meaning that you or I can use it to diagnose somebody else, just meaning that there is a methodology and a tool that helps those qualified to make those diagnoses. Now you can see in review and reflect number 2 a summary of some of the major categories of the disorders. Now, 2 terms you've probably heard before: neuroses and psychoses. Now we'll clarify here. Neuroses was used to be, it's not used, the term used anymore, but it was applied to disorders that cause people considerable personal distress, some impairment in functioning, but it didn't cause them to lose contact with reality or to avoid important social norms. This term isn't used anymore. Psychosis, this is a more serious disturbance that greatly impairs everyday functioning. It can cause people to lose touch with reality, to suffer from delusions or hallucinations, or both, and may require hospitalization. This is an area in which we are exploring, is this area, psychosis. Now remember, we're just doing a quick overview, and this is a very big field. So we're going to start with anxiety and obsessive compulsive disorders. We're going to review some, and then we'll move on to the next category. Anxiety is a generalized feeling of apprehension, fear, or tension. Anxiety is healthy and normal, and it's important to note. Anxiety is healthy and normal. Not all anxiety is bad. If it's a response to a real danger or a real threat, and it prompts us to take some sort of action, then that's where anxiety has been helpful and good. Anxiety is also and can also be unhealthy or abnormal if it's inappropriate, not at the right time to a circumstance, or if it's excessive, too high or too long, then it becomes a problem. Or even if it doesn't fade soon after the danger is past. So if you're anxious because a dog's in the room, and that anxiety goes way higher than what would be considered sort of normal, if you will, for presence of a dog, and that the dog leaves and your anxiety doesn't come down but stays up longer than what would be considered typical, then that becomes problematic. And it can also be something that interferes with a person's social and work activities. Some anxieties relate to groups of people, and if you were avoiding groups of people because of unmanageable anxiety, then that's the area of anxiety as a psychological disorder. Now, Generalized anxiety disorder is the first one we're going to look at, and it's a condition of intense and unrealistic anxiety that lasts 6 months or more. Now, it's really important when we go through each of these. All of us have had anxiety, so we have to be very wary of self-diagnosis with disorders because we don't typically understand the conditions by which things normally would have to happen to be seen as abnormal. We just think that because we've been anxious for 2 or 3 days, that in itself is a disorder. It's not. It's got to last at least 6 months or more. This excessive anxiety may cause people to feel tense, on edge, tired, irritable, difficult concentrating and sleeping. They may tremble, have palpitations, sweat, experience dizziness, diarrhea, and infrequent urination. Holy cow. However, it does help distinguish between anxiety that we may all experience, most of us, and anxiety in which might be a very small portion of the population. Generalized anxiety disorder substantially reduces the quality of life of sufferers, of which there is about 9% in North America. So if you're looking at 1 million people, 9%, although still a big number, and like 9% of 1 million is 100,000 roughly, 90,000, but 9% of a population is really small also. About 28% of people experiencing generalized anxiety disorder could have had it inherited, could have inherited it. And so there's a component that's pretty strong on hereditary. Now, panic disorder as a separate disorder can cause apprehension about reoccurrence and consequences of future attacks. Now, this can lead sufferers to avoid situations that they associate with previous attacks. Sufferers tend to overuse the health care system and are in increased risk for alcohol and drug abuse. Both biological and genetic factors appear to affect panic disorder. Now, I have a couple of friends who have had panic disorder, who experience that. It's not the same as having a momentary, oh my God, I've left my wallet at home and I'm about to pay for food. Panic disorder comes out of nowhere, and it's so debilitating, the person may in fact feel like something is seriously wrong with their body because their body is revolting inside. The heart rate goes up, palpitations, sweating, feeling totally in a flight or fright mode. It's not the same as having some anxiety or feeling a little stressed. And it's an important distinction that we must make. Now, into another area that we may have more familiarity with people who experience phobias. A phobia is a persistent, irrational fear of an object, a situation, or an activity that a person feels compelled to avoid. Now, there are 3 categories or classes of phobic disorders. There's the first one, which is what's known as agoraphobia. Now, these are the fears of being in situations in which escape is impossible or help is not readily available in case of incapacitating anxiety. And that's an important, if you've known people who have been clinically diagnosed with this class of phobia, it's very debilitating. And we'll get into that a bit. There's more detail to be brought out in all of these that we'll be discussing in this chapter in a larger class of abnormal psychology. So some of this is going to be a little quick and maybe not enough detail for you to get a good handle on. So be sensitive that this isn't an abnormal psychology class. So the second group, agoraphobia, is the first. Second class is social anxiety disorders. And here the fear of social situations in which one might be embarrassed or humiliated by appearing clumsy, foolish, or incompetent. Now, it's important to note the person isn't always and isn't necessarily doing things inappropriately wrong or clumsy or foolish or incompetent. But it's the fear that they will feel and might come across that way that brings this degree of anxiety. I've known people who will throw up before or won't even show up for class, doing a presentation, the idea of being in front of people. And I understand, I get. Okay, specific phobia is the third. Now, these are marked fears of a specific object or situation, and it's a catch-all category for phobias other than agoraphobia or social anxiety disorder. Now, these include situational phobias, whether it's the elevator, tight or enclosed spaces, airplanes, things like that. Those are situational. They could be fear of natural environments. So storms, water, heights can all be a part of that. They could be a fear of animals, dogs, snakes, spiders. Or blood, injection, injury, seeing blood, receiving an injection. These are all parts of specific phobias. Now, what causes phobias? Well, genetics appears to play a role, as does learning, direct and observational. Just meaning that either we can learn our own associations, getting in an elevator and having been stuck in one before. I remember being stuck in one in London at the hospital. 10-story building, stuck in the elevator for 2 hours with 6 other people. Not everybody handled that situation well. And it's you can't blame anybody. Being in a situation where you can't change the outcome and you have to deal with it. Very different experience. So what causes it? Well, that experience, observational. You can watch somebody else have a negative experience and then sort of associate that negative experience with you. It's worth noting, and I'm going to repeat this. I think I mentioned that not just regarding phobia, but with all disorders, this is to remember that the 6 conditions to differentiate abnormal and normal behavior. Behavior needs to be within cultural norms, not cause personal stress, not be maladaptive, not be a danger to oneself or others and persons, and person is legally responsible. All of these conditions must adhere to those. And so we start to narrow that the likelihood that anybody can be diagnosed with OCD, depression, anxiety disorder is small because there's just not that many people diagnosed. And so a lot of times we self-diagnose and it's not clinically done and it's not an accurate representation. And from my perspective, when we start saying things like, and we'll get into this with this next disorder, obsessive compulsive disorder, when we start saying that my OCD is kicking in, when we mean that we're organizing things in a tight, neat, and organized pile, we are inadvertently not understanding well enough and making it appear that somebody else who's been clinically diagnosed with obsessive compulsive disorder is somehow not trying hard enough not to be. And it's not the same. Being self-diagnosed and misunderstanding what OCD is not the same as understanding what it is and being diagnosed. So let's look at that. Obsessive compulsive disorder is a disorder in which a person suffers from obsessions and or compulsions. Let's look at that a little more. Obsessive compulsive disorder is characterized by, the first is obsessions. These are persistent, reoccurring, and really important here, involuntary thoughts, images, or impulses that cause great distress and anxiety. Okay, that's obsession. Now, unless you've been diagnosed, that doesn't actually make as much sense because most of us don't have obsessions where if we don't act on them, something terrible will happen. That's where the great anxiety and distress come from. The compulsions, persistent, irresistible, irrational urges to perform an act or ritual repeatedly. These ritualistic and repetitive behaviors reduce the anxiety caused by obsessive thoughts. Common compulsions include cleaning and checking behaviors. Now, I know some people who suffer from OCD and have learned to cope with it. Many people will recognize the irrationality of the compulsion. I check the locks every time I leave the house 12 times before I can feel I can leave the house. I have a friend who, for quite some time, struggled with driving because he kept stopping and having to get out of the car and check to see under the car whether he hit somebody. It wasn't that he really believed that he did, but it was the compulsion that if he didn't check, he would never know, and then that caused him great distress. And so these things are not as simple. In fact, if you take abnormal psychology, you'll see that someone who likes to organize their papers in a particular way, you're not talking about OCD, you're actually talking about obsessive compulsive personality disorder, and that's an entirely different disorder. And even that's not the same as somebody who just likes to keep things neat. All right, so it's important to note that these are not choices. These are intrusions, and one is compelled to respond as they do. This is not a weakness of a person. It's a condition. And remember what separates what we call normal and abnormal behavior. Now, a departure from this, the biological factors are thought to play a role in obsession and compulsions. Here, heritability and serotonin functioning are important. Now, we're going to move into a different category. This category is known as somatic symptom and related disorders and dissociative disorders. Now, somatic symptom disorders involves bodily symptoms that cannot be explained by known medical conditions. The symptoms are due to psychological rather than physical causes. Now, an example of a somatic symptom is illness anxiety disorder. Now, you might know this by its oldest name, hypochondrias. This involves a preoccupation with the signs of some serious disease involved in you. The person is terrified of being sick, worries constantly, goes to doctors repeatedly, will do what is known as doctor shopping. That if I don't get the correct response from this doctor, I'll go to another doctor and then another. And it becomes a preoccupation with every sensation that their body has, despite any reassurance for doctors to the contrary. It is something that really motivates them. Now, conversion disorder, this involves a loss of motor or sensory functioning in some part of the body, such as paralysis, numbness, or blindness, for which there is no physical cause, but solves some psychological problem. I'm aware of people, I've seen and read case studies of people who have gone out of their way to try to find a doctor that will remove an arm or a leg from a person because they don't feel as if it's theirs and it doesn't belong to them, it's not functioning, they want it removed. Excuse me. Now, dissociative disorders, this involves a break in consciousness, memory, even both. Under stress, a person loses the integration of consciousness, identity, and memories of important personal events. They provide a mental escape from the intolerable circumstances. Now, we're going to look at two types of dissociative behavior. One is called dissociative amnesia, and the other is known as dissociative identity disorder. Now, we'll start with dissociative amnesia. No physical cause, such as a blow to the head, is present. Rather, the traumatic experience, a psychological blow, so to speak, or an unbearable anxiety situation causing the person to forget or to escape by forgetting. And in fact, they just don't have memory. It's an amnesia. Now, extreme circumstances, dissociative fugue, people forget their entire identity. Travel away from home, they may assume a new identity somewhere else as a reaction to some severe psychological stress. Now, dissociative identity disorder, this used to be known multiple personality disorders. Two or more distinct and unique personalities occur in the same person, each taking over at different times. They'll switch back and forth, and if there's multiple, they each switch given circumstances. This used to be known as multiple personality disorders. Now, most patients are female and victims of early and severe physical and or sexual abuse. They typically complain of periods of lost time. Now, there is a host personality. This is the one who's got sort of executive control over the body and the greatest percentage of time. The alternative personalities or alter personalities, they may differ radically. These alternative personalities may have accents, different vocabulary, different tastes of clothes, hobbies, and could be of different genders and different ages. It's pretty remarkable. Okay, that's the end of part 1. We'll carry on the continuation of this chapter in part 2. I hope this is going well for you. Good luck, everybody.